let's first start with the phase 3 study that we all are excited to hear about. Perhaps the results will come out later this year or early next year, and that's from Independence. That's the study where patients who are on ruxolitinib and are requiring transfusions with a predefined definition of what that exactly means on a stable dose of Rux, they are randomized to the addition of luspatercept or placebo. Once again, our audience would know that luspatercept is FDA approved for treatment of beta thalassemia and MDS. So the same dosing schema, more or less, 1.33 mg per kg increased to 1.75 mg per kg. So that same dosing schema is being also utilized in the Independent study. I believe the enrollment is completed, but we are waiting on seeing the top-line results and the full set of results. What is important to note there is that the phase 2 results look very exciting, especially for patients who were on drugs and requiring therapies. That's the anemia that's difficult to treat. That's the one that concerns us most. And I might have said that those patients might be the ones who would benefit the least from luspatercept. Turned out they actually benefited the most from luspatercept, the cohort 3B from the ACE 536 MF001 study.
And there's already a lot of off-label use.
Absolutely.
NCCN endorsed
guidelines
as well.
Can be utilized if one wants to use it right now before the label approval. So that's another phase 3. Well, what else is going on? There is another BET inhibitor. For example, Incyte has a BET inhibitor called INCB057643. It's being studied both as monotherapy and in combination with Rux. There's also an arm for essential thrombocythemia. I can just summarize and say that preliminary reports are suggesting good spleen and symptom responses, both as monotherapy and in combination for suboptimal responders to Rux. ET, or essential thrombocythemia, results are yet to be shown. There's also an arm for upfront therapy. So that's the BET inhibitor from Incyte. There is also nuvisertib. That's a PIM1 kinase selective oral inhibitor. We know that PIM1 kinases have a role to play in myelofibrosis. Previously, PIM1 kinases or PAM-PIM kinase inhibitors have been studied, and there were some issues related to cytopenias, but with the selective PIM1 kinase, perhaps that should not be the case. And so far from the ongoing study, the results which are looking most promising are especially with regards to symptom improvement. And those symptom improvement responses have been correlated to decreases of certain cytokine levels. We shall see where the study goes. Very important for me to state here, which is an exciting thing in the field, and that's the fact that this drug is also being looked in combination with momelotinib. Perhaps for the first time that we are using a different JAK inhibitor in combination. Now, let's put that on the side and go to another one. That is imetelstat. Imetelstat is FDA approved for patients with MDS who are requiring transfusion, and they have been through ESA therapy or cannot be good candidates for ESA therapy. So it's already FDA approved there as of 2024, I want to say. That was looked upon in the phase 2 EMBARK study first, and 2 different doses were looked into. Probably the result that led to the most excitement was that the higher dose, which was 9.4 milligrams per kilogram dose, led to an overall survival in a relapsed refractory patient population of almost 28 months. All databases and all data would suggest so far that these patients have a median survival around 15 months or so. So it almost doubled that. But that's from phase 2. There's an ongoing phase 3 IMPACT MF study, taking patients with relapsed refractory myelofibrosis and randomizing those patients to either imetelstat or to best available therapy. The results hopefully will come out perhaps maybe later this year or early next year, and we shall see whether this trial with an OS endpoint truly paves the way for second-line use.
The only OS primary endpoint trial in the field, really.
Right.
So thank you, Pankit, for that great overview. There are 2 other groups of drugs. So one is the anemia, and one is the what I call targeting driver mutations better, and we'll get to those. So Naseema, you've done a lot of work with DISC-0974, the anti-hemojuvelin. We were already talking about luspatercept, which of course is already being used, and we are going to wait for the phase 3. We are also combining luspatercept with momelotinib in the ODYSSEY ODYSSEY trial. But tell us about the DISC-0974, a very unique agent.
So the agent is an anti-hemojuvelin antibody. As you mentioned, it suppresses hepcidin. And we all know that in myelofibrosis, hepcidin levels are elevated. It is distinct from luspatercept in that it acts through the SMAD158 as opposed to SMAD23. So they are similar yet different. They are both in the TGF-beta pathway, but that's why I think the responses are differential too. So when the DISC-0974 in MF has shown very encouraging data, both as monotherapy and in combination with JAK inhibitors. As opposed to luspatercept, we are waiting the independence data. But in MDS, the DISC-0974 is not as effective. So that kind of also highlights the differential pathogenesis of the two diseases. MDS-RS is more ineffective erythropoiesis as opposed to iron-restricted erythropoiesis. So actually, these agents are very interesting because they're not only giving us response data, but having us track back to the pathogenesis of anemia, which is similar yet different for the two entities.
Right, and then maybe a bit more similar to luspatercept is elritercept, right? Actually, it's kind of, my understanding is elritercept is a bit more similar to sotatercept, which preceded luspatercept and has now gone in a different direction, with pulmonary hypertension being the indication for it. So it's really kind of left the heme malignancy world. But elritercept is something that Claire Harrison has presented, and this could be an interesting, somewhat unique activin receptor ligand trap, also being studied in MDS. Phase 3 announced, I think started also, and then with the MF results, more to come. So absolutely. So, and this goes back to your point, Naseema, earlier, of these drugs. Maybe they're going to be able to allow us to maintain Rux dosing, right? Like support the anemia and maintain that dose intensity.
And it's also shedding light on combination therapies with synergistic activity, like momelotinib and luspatercept, the ODYSSEY trial that you referred to, because luspatercept, as we know, is more of an erythropoiesis maturation agent, and this one would suppress the hepcidin. So they're kind of synergistic.